Hello guys and welcome to my channel. Today we are going to have a discussion on the topic of asthma. So before moving forward, let us see the top points under which we are going to discuss our topic. So let us now take one point at a time. Let us start by what is the definition of asthma. So asthma is defined by the history of respiratory symptoms such as wheeze, shortness of breath, chest tightness and cough. And these symptoms they vary over time as well as with intensity. And there needs to be a variable amount of expiratory airflow limitation. So this is the definition that has been taken from GINA, the Global Initiative for Asthma, the 2022 guidelines. So I would like to stress on 2 points here. If you look at this definition very carefully, then you will see that we have basically defined asthma clinically. And the second thing to note is that the airflow limitation that we are talking about, that airflow limitation is basically expiratory in nature. So it is not an inspiratory kind of an airflow limitation. So I would like you to remember these 2 points. Moving forward, now we are going to discuss on 2 things. But before we move forward, let us just have a quick look at the global prevalence of asthma. So globally, asthma affects around 300 million people. And accounts for 2,50,000 deaths. In adults, asthma is basically found in 10 to 12% of the population. Whereas for children, asthma is found in about 15% of the population. One more thing, in the upcoming slides we are going to discuss about 2 more terms. One of them is risk factor. The second term that we are going to discuss is trigger. So before moving forward, let us just have a brief understanding of what these 2 terms means. So basically, risk factor, what it means is that these factors will predispose the patients towards developing bronchial asthma. But the mere presence of risk factor does not guarantee that a patient will ultimately develop bronchial asthma. Yes, the chances of developing bronchial asthma obviously will be high, but it is not a guarantee. Whereas trigger basically means that these are those factors that worsen asthma. That means for a trigger factor to act, the patient must already have an established asthma. So in a nutshell, the presence of risk factor does not guarantee that the patient will ultimately develop bronchial asthma. Yes, it does predispose towards developing bronchial asthma, but the trigger to act, the patient must have a established bronchial asthma in the first place. So now what are the risk factors? The risk factors are broadly divided into the endogenous as well as the environmental factors. So in the endogenous factors, we have got the genetic predisposition, atopy, airway hyperresponsiveness, gender, ethnicity, obesity, as well as early viral infections. Now the most important risk factor among these is atopy. This is the most important risk factor. And airway hyperresponsiveness. This is actually the physiological abnormality of bronchial asthma. The environmental risk factors are indoor allergens, outdoor allergens, occupational sensitizers, passive smoking, respiratory infections, air pollution, diet, dampness and mold exposure, and drugs such as paracetamol or acetaminophen. So as I've already told you that atopy that we have just now studied, which is an endogenous risk factor, this atopy is the most important risk factor for the development of bronchial asthma. In fact, non-atopic individuals, they have very less chance of developing asthma. What is the cause for this atopy? The cause is presence of immunoglobulin E antibodies. In fact, 80% cases of bronchial asthma, they are actually linked with allergic rhinitis. That is, in 80% cases, you will find that allergic rhinitis and bronchial asthma in a patient coexist. The second thing that we have also studied is the genetic predisposition. So the first thing to note is that this is also an endogenous risk factor. So first thing to note is that this is a polygenic disease. That means it is not controlled by the single gene. But the most consistent genes, they are actually located on chromosome number 5q. Now this is a very important point I would like you to remember. It is a polygenic disease, no doubt, but the genes that are most consistently associated with bronchial asthma, they are located on chromosome number 5q. And the interleukins that are mostly associated with developing bronchial asthma, they are interleukin 4, interleukin 5, interleukin 9 and interleukin 13. Now here's a little trick to remember this. If you add 4 and 5, you are going to get 9. And if you add 4 more to 9, then you are going to get 13. Right? So interleukin 4, 5, 9 and 13, these are the interleukins that are most commonly associated with bronchial asthma. We have also studied about viral infections. Now for the viral infections, again an endogenous risk factor, for them the presence of the rhinovirus is actually a common trigger which will ultimately cause exacerbation of asthma. So these are a few important points. Moving forward, the triggers for bronchial asthma. The triggers are allergens, upper respiratory tract viral infections, exercise and hyperventilation, cold air, sulfur dioxide and irritant gases, drugs such as beta blockers and aspirin, stress, and irritants such as household sprays and paint fumes. So see, drugs such as beta blockers and aspirin, they are triggers, whereas drugs such as paracetamol or acetaminophen, they are actually a risk factor. So what are the pathological findings? One of the most consistent pathological finding is thickening of the basement membrane. Now, this thickening of the basement membrane occurs basically because of the subepithelial collagen deposition. The next thing to remember is that there are increased number of epithelial cells in the lumen. Now, why are there increased number of epithelial cells? Because the epithelial cells, they are actually shredded in the lumen. So epithelial shredding occurs, and ultimately this shredded epithelium is present in the lumen. Airway wall is thickened and edematous, especially in case of fatal asthma, and there is occlusion of the airway lumen by a mucus plug. And this mucus plug that we are getting, this mucus plug is basically formed by the mucus glycoproteins. And these mucus glycoproteins, they are secreted from the goblet cells. Along with that, along with the mucus glycoproteins, also the plasma proteins, they also form the mucus plug. And why do we get these plasma proteins? Because of the leaky bronchial vessels. So the leaky bronchial vessels, they are actually extruding the plasma protein, and these plasma protein along with the mucus glycoprotein from the goblet cells, they together form this mucus plug. And also vasodilation and increased number of blood vessels. And this increased number of blood vessels, this thing is actually known as angiogenesis. So now let us discuss these points a little bit further. The airway mucosa, in case of a patient of bronchial asthma, the airway mucosa, that will be infiltrated with eosinophils. So we are going to get eosinophilic infiltration. Along with that, there will be the T lymphocytes. And there will be activation of the mast cell. So three things are going to occur. The first one will be, there will be eosinophilic infiltration. Second, there will be infiltration of the T lymphocytes. And the third thing to occur is that there will be activation of these mast cells. Right? However, one thing to note is that for bronchial asthma, the degree of inflammation that we are getting, it is actually poorly related to disease severity. So another very important point to remember, that high degree of inflammation does not necessarily mean a very severe disease for bronchial asthma. In the airways, there can be structural changes. And these structural changes in the airway is known as airway remodeling. As I've already told you, so there will be eosinophilic infiltration and there will be deposition of subepithelial collagen. So this subepithelial collagen that we are getting, this is actually a marker for eosinophilic infiltration. Because the eosinophils, they actually release fibrogenic mediators, hence this collagen is actually a marker for the eosinophilic infiltration. And as I have told you already, that airway hyperresponsiveness, this is actually the physiological abnormality. So whatever we have discussed up till now, that is the pathological abnormality, but the physiological abnormality is airway hyperresponsiveness. Please remember this point, it's very important. So now let us go into pathophysiology a bit more detailed way. So we have got an allergen. Now this allergen can either go into the dendritic cell or it can go to the mast cells. Now the dendritic cell or the mast cells, they are basically the antigen presenting cells of the body. So now the dendritic cell, it can activate the T helper 2 cells or the eosinophils, and similarly if it goes into the mast cell, then also it can activate the eosinophil as well as the neutrophils. So basically, as you can see, that T helper cell will be activated, eosinophil will be activated, neutrophil will be activated. Now let us see what happens. So as I've already told you that you have got an allergen, and that allergen, let us suppose that it is activating the mast cells. So this activation of the mast cells is basically responsible for the acute bronchoconstrictor response. Please remember this thing, it's very important, that the acute bronchoconstrictor response is because of the activation of the mast cells. In case of exercise induced asthma, in case of hyperventilation induced asthma, as well as in case of fogs, asthma induced by fogs, the mechanism of acute bronchoconstriction is activation of the mast cells. Now this activation of the mast cells, that thing does not occur in case of a patient with eosinophilic bronchitis. So one of the differential diagnosis is eosinophilic bronchitis, and how can you differentiate? These activated mast cells you are not going to find in a patient of eosinophilic bronchitis. And suppose if the allergen that we are getting, that is being presented by the dendritic cell, then this thing basically occurs because of a low affinity IgE receptor. The low affinity IgE receptor, which is FC, the fragment crystallizable, epsilon R2. So FC epsilon R2, this is the receptor that is responsible for activating the dendritic cell. Now once these dendritic cells are activated, then they are going to activate the T helper 2 cells. Now if the in case of a normal person, actually the T helper 1 cells they predominate, but for a asthmatic person the T helper 2 cells are going to predominate. So now what are the clinical phenotypes? The first thing is allergic asthma. As I have already told you that this allergic asthma, this is the most common form. It mostly occurs in childhood, and the response to corticosteroids is actually very good. The second thing to note is that non-allergic asthma. So obviously, as you know from the name, that it is not associated with allergy. But however, it has got a less short-term response to the inhaled corticosteroids. The third point is adult onset or late onset asthma. For the late onset asthma, remember a very important point, women are affected more than the men. And this form of asthma either requires high dose of corticosteroids or they are completely refractory to the corticosteroids. The next is asthma with persistent airflow limitation. So the airflow limitation in this case is either persistent or it is incompletely reversible. And this basically occurs, that is either it is incomplete, reversible or persistent, because of a phenomenon that we have already discussed, that is airway remodeling. Another one is asthma with obesity. So in case of asthma with obesity, we are going to get predominantly respiratory symptoms. And there is very little eosinophilic infiltration. So what are the clinical features? The features that actually increase the probability of a patient having asthma are presence of wheeze, shortness of breath, cough and or chest tightness. The patient can experience one or rather greater than one of these symptoms. The symptoms are worse in night or in early morning. The symptoms they vary with time as well as the intensity of the symptoms, and they are triggered by the viral infections such as common cold, exercise, allergen exposure and changes in weather. The features that decrease the probability of a patient having bronchial asthma: if the patient only has isolated cough but there are no other respiratory symptoms, if there is chronic production of sputum, the shortness of breath that the patient is having is associated with dizziness, lightness or peripheral tingling, if there is chest pain, if there is exercise induced dyspnea with noisy inspiration, because we have already studied the airflow limitation for bronchial asthma is actually expiratory and not inspiratory. So that's it for today, guys. In the upcoming lectures, we are going to discuss about the drugs for bronchial asthma and the latest guidelines for asthma treatment. So do check out my other videos. The link will be given in the description box as well as in the I button. So thank you very much. Until next time.